So good evening, everyone. I hope all of you are doing well. And today we will talk about perils of the operative technique in total knee arthroplasty and something which is called the gap balancing. First of all, we know in the previous lectures, in the previous webinars about the malalignment and alignment and technical alignment of the total knee and how to perform it. Now we will talk about the practical issue about this. So first of all, I have nothing to disclose regarding the implant or systems, but we will show you some pictures of the systems what we have got in this webinar. As a learning objective, we will talk about technical steps in osseous cutting and the application of the alignment in both components regarding the femoral and tibial components, and how about the mismatch in the balancing after trial application. So we remember that in the approach of the knee joint, after completing the approach, which is the standard medial parapatellar approach, the femoral preparation will be started. Some of the surgeons suggested that femoral preparation first or no, the tibia first. This is a surgeon preference. Actually, there is no difference between both of them. But most of the surgeons will start the femur as a preparation for primary surgeries, especially for those who are doing the cruciate retaining our CR knee, because after femoral resection, it can be completed. The tibial exposure can be facilitated easily, as you see here. So in the revision surgery, the vice versa is occur. The tibia first, and then the femoral preparation after that. But we will have some discussions in the revision surgery in the few next webinars. And I hope so we will be all in touch. As the revision surgery after removal of the component, they will start as the tibia first procedure that creates a flexion gap, or that is using the tensors. Okay. So differences are the tibial preparation, as we said, it will cause and use the flexion gap symmetry tensor or a spacer block. This will show you earlier and later in this webinar. And the femoral preparation can be established the extension gap first. With the rotation of the femoral component, the rotation will affect the flexion gap as well. So how about the femoral preparation? As you see, after flexing the knee into 90 degrees, the femoral can be prepared first, but how to prepare it? You have to remove this is the picture of removal with a fine osteotome, the intercondylar notch osteophytes, some of the knee in severe osteoarthritis, you may see this area. You have to evacuate all the osteophyte in order to see the PCL, especially the origin of the PCL. So after that, you can draw the white side line. And if you remember, the white side line is the lowest point from the trochlear sulcus into the uppermost in the notch. And here is what you see, the PCL origin. This is the medial and this is the lateral. This is the medial and this is the PCL origin. And you evaluate 10 millimeters from the origin of the PCL from the femoral attachment into this point, which is 1 or 2 millimeter just medial to the white side line. هاي النقطة اللي هي احنا رسمناها بالبري-operative alignment بالمحاضرة اللي قبلها. In the previous webinar, we suggested that the previous X-ray, which is in the sagittal plane or lateral view, we draw the anatomical line of the femur that will not intersect the Blumensaat line. So from the anatomical line on the lateral view, we measure this distance, and it will be either 7, 8, or 10 millimeters from the Blumensaat line. اللي هي the entry point of the femoral component or the cutting box. Okay. So if the canal were to be entered in the true center of the notch, the valgus angle is chosen, and this is to be effectively increased by several degrees. and we knew how to measure the degrees of valgus cut. Regarding the femoral preparation, broaching of the central canal is either by a small gouge or initial drilling or complete reaming. حقيقة هاي الموضوع يعني a small gouge, some of the system they apply a small gouge first in the point we are drawn, and then initial drilling, some of the surgeons, they prefer not to drill all the way into the femoral canal because some of the systems have applied a very small tip in the drill, in the reamer, which is about 1 centimeter, and then it will be precisely put in this point where you are going to do drilling of the femur. And then some of the surgeons, they not do drilling all the way, and they replace it for 5 centimeter only regarding the suprapatellar notch from the femur, and then remove it, and then put it the IM rod immediately. Or some of the surgeons, as their experience, a complete reaming of the canal. The reamer must be larger than the IM rod. All the system applies that because the IM rod here, it is actually smaller by few millimeters. And in this way, many surgeons have suggested to do suction and irrigation of the canal of the femur. However, it is not necessary because it will not act as there will be a fat embolism or else. It is only that the IM rod, whenever it is smaller than the reamer, it's very safe. But here is the difficulty. In rare occasions, some difficulties suggested that the introduction of the IM rod is so difficult. You cannot force it in order not to penetrate the cortex. So use a smaller diameter IM nail and then broach it, and then you put the standard IM nail. What we are going here is that when you have the entry point is positioned errorly, as you go lateral more, you may have 1 or 2 degrees of the valgus angle, and it will cause a varus cut. Other thing is that oversizing the canal. If you are doing an oversized canal and you choose the small diameter IM rod, it will be toggle, and there will be difference in 1 or 2 degrees error. And this picture shows the valgus cut of the femur, which is flushed on the most effective side or the medial side. And then you apply it by 7 or 6 degrees valgus. As you see and as you saw in the previous webinar, it is perpendicular. The cut will be perpendicular to the mechanical axis. And we see how in the tall, in the short persons, and how about in valgus knee, how we can do the differences between them. So about the distal femoral resection. As you see, this is the jig of the IM rod, and this part, this is assembled together with that of the distal femoral cut. Okay, and we will see that the amount of the bone is equivalent to the thickness of the metallic distal femoral cut. النقطة اللي نحن نشوفها هنا إنه what we remove from the distal femur is that the same thickness of the component or the original component of the prosthesis. Regarding the distal femoral cut, it is approximately, they add 2 millimeter of the thickness of the cartilage, whether it is cartilaginous still there or not, from the true anatomic amount. So in cruciate retaining implants, originally they will cut 7 millimeter, and in PS design, it is 9 millimeters. So in flexion contracture, remember that you may not go through a way for the zero. يعني احنا بدنا نخليه على النقطة zero، هذه احنا بدنا نسويها 9 millimeter cut. In the flexion contracture, when you need more extension, so you need to do an excessive cut of the distal femur, so you add a +2. The PL is that when you have the slope, هي قايسيها standard, it's 1.27 millimeter. So the saw should be in 1.2 or 1.25. يعني ما رح ناخذ احنا thin saw in order not to toggle. That's why the saw should be held firmly with the flat surface of the saw blade in the slot and keep it flush with the distal face of the cutting slot. The saw blade هنا should be allowed more freely without any jamming. And you see here in this picture the correct positioning of the pin in the cutting box, which must be perpendicular, and allow the slot is perpendicular to the sagittal plane of the femur. If you do it over tightening, it will not. It will cause more anteroposterior cut. It is يعني حتصير بها slop, which is not a slot. Regarding the femoral size, and after we are cutting this, and we know all of us in the previous webinar, we suggested that it is perpendicular to the mechanical axis by the 7° or 6 degrees valgus. The femoral sizing and rotation after that, the posterior referencing or anterior referencing, and we will see later what are the differences. I should choose the posterior references. As you see, there are 2 feet that are sit together in the posterior condyle. So it will size the femur from the posterior condyle upwards. And this will restore the joint line in flexion. It will balance the PCL in cases of you are choosing cruciate retaining, and minimize the chance of midflexion instability. So after you put these feet together, you have a mobile stylus that is put on the anterior cortex of the femur. And then you have these gauges from 1 to 9, from 2 to 10. This is odd and even number. These are the sizes that you are inserted. After that, when you see from the stylus to the feet, you suggest the number of the size of the femur from the anteroposterior diameter in flexed knee. A problem usually has been occurred when you have a larger size or a smaller size. If a larger size has been chosen, especially between 4 or 5 or D and E in some instance or some systems, بيناتهم احنا ممكن ان نختار the larger size in order to reduce the risk of notching. Do not downsize the femur, والا رح نصير بها نوتشنج، ورح نتعرف شنو النوتشنج بالسلايدات الجايه ان شاء الله. There are some exceptions when you are not choosing the large one. In cases of a flexion contracture, when you have a flexion contracture perioperatively, you can see that the anterior cutting, the anterior cut, it will be more proud anteriorly, and it will cause a reduced excursion of the quadriceps tendon. The other thing is that when you have a female patient where the mediolateral diameter is smaller than AP diameter, بهاي الحالة حلوها المانيفاكتورر or systems, they have chosen that a gender type of the femur. And in this way, if you choose the female with a larger AP diameter, the mediolateral also will be large if there is no gender. And it will cause overhanging either medially, laterally, or both. Overhanging of the one or side, it will cause overstuffing, which means that there is inflammation of the medial or lateral collateral ligaments. You can see here in these cases, like this is the cross section of the femur. This one is the true the femur, and here is the component when it is exchanged. And you see that in A there is a downsize without notching, and there is in B upsizing, and you will see what are the differences between down or up. This will cause an increase in a flexion gap. This will reduce the flexion gap. Here is downsize, but you have see that in figure C, there is a notching of the anterior cortex, and it may risk the supracondylar fracture. And here we can see in D, this is an overstuffing, or it may cause overhanging anteriorly and reduce the excursion of the quadriceps tendon. Okay, what about femoral sizing and rotation? Still we are sizing and we choose a larger one. But what about a smaller? If we are choosing a smaller one, you want to reduce only the anteroposterior diameter. This is the jig where you put the both feet under the posterior condyle. And here you can put the stylus anterior cortex. And then you put these pins in order to make the exact size. Before you are starting with these cutting boxes, you reduce only the AP diameter. So some systems allow for 3 degrees of flexion of the anterior cut, which means if you go back here in this way, in this picture, let's take this one, there is a 3 degree, not a flash, it's 3 degree of anterior cut of the anterior offset. This will allow the condylar resection more, which increase the poly insert. So it may cause hyperextension without consequences, and we will see in another slides. So first, check rotation with a large size box like this one. Before you cut it, you exchange into another one which is smaller. تختار الصغير وبدل ما تروح على you are doing the cutting from the slot, put it above it in order not to notch the anterior cortex. There are some notes, as we said. Some of the systems allow flexion of the 3 degree of the anterior flange. You can see this picture, how the femur is put in anterior flange with the 3 degrees, like that of Stryker. It will allow a hyperextension of the knee, and there are no consequences at all. But we have something important, is that the slope of the tibia, احنا من قلنا بالalignment انه من يكون بالsagittal plane there is a slope of the tibia. هنا بهيك system اللي حيسوي flexion of the component in 3 degrees of the anterior in order to maintain more posterior resection, and اللي حيعوضه بالcomponent هنا by without an offset. It will not cause and it will not do, these systems will not do any posterior slope of the tibia. Otherwise, if you do sloping of the tibia, there will be here a deleterious and impingement, post-impingement syndrome, which is on the cam, on the post of the polyethylene, and may cause a backside wear. Another note is that the differences between the anterior referencing technique and the posterior referencing technique regarding sizing of the femur. And with the anterior reference technique, which means that we are doing references from the anterior cortex without notching, but here you can do variable sizes of the posterior condylar offset. This is rarely done, but most of the system, they applied for a posterior reference technique. That is to say, we are having these feet on the posterior condyle and then upward measuring the anterior cortex without notching or overstuffing. To our knowledge, there is no high-level studies that show the differences between two techniques. So, هسه كملنا احنا sizing of the femur and distal femur, and then size, and then we are going to rotate. In the previous alignment, in the previous alignment webinar, we said that there are 4 reference lines. The first reference line, which is shown in both pictures, is the AP white side line, واللي قلنا عليه from the lowest sulcus into the upper part of the notch. And we have a perpendicular line, which is the epicondylar axis, واللي قلنا عليه أنه هو ممكن أن يختلف ما يكون يعني 90 degree exactly. It is actually from 80 to 110. So that's why we don't depend on these lines only. You have to see that in normal knees or in cases of varus knees, you have to see the posterior condylar axis, which is a 3 degree internal rotation in relation to the transepicondylar axis. And we saw how if there is a hypoplasia of the lateral cortex, lateral condyle, and there some of the severe valgus knees. And what will we do in the rotation? So يعني فد ملاحظات بسيطة أنه إحنا نعتمد على 3 degree of this line and the epicondylar axis and we go external rotation in 3 degrees. Do not internal rotate. There are both techniques, measured and resection and gap balancing. We can use it after you put the external rotation guide and the resection guide. You can do measured resection, what we resect from the bone. طبعا احنا من الميديال لانه anatomically speaking the medial side is posteriorly projecting more than the lateral side, especially in varus. ولهذا احنا ممكن انه نقيس هذه القطعتين اللي رح نشيلهن. The gap balancing means that we can do either the tension, the tensometer that is put from the tibial cut into the posterior cut of the femur, or you can have the space blocker. The actual effect of rotation, this is so important, on the displacement of the trochlear groove shows that every 4 degrees of femoral component rotation, the groove displaced 2 millimeters medially for the patellar tracking. So what we are doing is that we can do patellar tracking and component by component external rotation. There are technical steps. Flexion of the knee and up to 90 degrees. If you have got it tight, you cannot go more than 90 degrees. So you have to external rotate the tibia more and add both homins on the lateral compartment and medial compartment. اللاترال compartment دائما احنا نخليه على اللي هي مال الباتيلر surface. Do not put it on the tendon, otherwise you may have injured the tendon itself. Place the femoral cutting jig at the distal femur with external rotation holes. We did an external rotation guide and then we pin them. After that, you remove the external rotation guide and then you bring up the cutting box. With the posterior arms of the jig firmly attached to the posterior condyles. Do you remember that? You have to make these are firmly attached. Pins are placed at rotation side and the cutting box lateralized without overhanging. And we will see why it is that. Start anterior. First of all, we start from the anterior resection, the posterior resection, then the chamfers anterior and posterior. It doesn't matter which are the first, but you have to do these anterior and posterior chamfers cut. Almost always, when you are cutting the distal femur, protect MCL and LCL by homins during your resection. Avoid notching from the femoral cut. First of all, as we said, the trochlear resection is made first, and avoid notching of the cortex. Preoperative lateral film is very important. Check if there is any hypertrophied or osteophytes. You can do pre-cut before the anterior chamfer cut in order to see the anterior cortex, or if there is a hypoplasia or patella alta. So pre-cut the osteophyte, as we said, to expose the junction with the anterior cortex. Some of the surgeons remove every fatty tissue from the synovium. You can remove only the synovium, and sometimes you are evacuating even the periosteum, and this will cause a hypertrophic ossification, which may limit the quadriceps excursion. So it is not of use. You just feel the anterior cortex, it is safe. And as we see, some of the system has a few anterior flexion of the anterior flange in order not to notch the femur. It is important not to resect the posterior condyle regarding the posterior condylar resection without uncontrolled saw blade exit. هنا we can cause a serious injury of the posterior structures, and there are so many injuries in the popliteal artery or vein. After you resect the distal femur, you can go for the intercondylar cutting box اللي هي احنا نستعملها بالcases of posterior stabilizing knee. The cutting box jig is put over the distal femur and using a reciprocating saw rather than oscillating. So if anyone has a question, please you can write it down in the chat, and after the end of the lecture we will answer it happily. هذا فيما يخص موضوع femoral addressing. So what about the tibia? The tibia, we have measure resection technique rather than the gap. And after it will we will have the gap, yes, of course. And we have some component thickness. What we are measure the resection is that when we have got the external or internal guide, you can measure from this one up to the resected distal femur, either in the extension or in a flexion. In general, you can see that the component thickness is 10 millimeter from the proud or more prominent plateau. So in cases of varus knee, it is the lateral plateau that we are taking 10 millimeter. How is that occurred? Simply, the external and internal as well, it has a stylus like that of the femur. هذا الستايلس إذا نخليه إحنا بالlateral side, it will read as 10 millimeter. So that is why this one is loose. You can do it upwards or downwards until you can see the stylus is touching the lowest point of the lateral condyle or lateral plateau of the tibia. Then you can tighten it from here. So if you have this one, you can put the stylus on the medial and you see it is only 2 millimeter or 0 millimeters. So in cases of more than 20 or 20 or 13 millimeters, it will be removed. In these cases, some of the defects may occur and may be needed of either cementing or augmentation according to defect. وهذا المحاضرة حتكون الجايات إن شاء الله difficult primary, how to deal with the defect in the tibia and the femur as well. So what about intra versus extramedullary devices? Many surgeons prefer this and that. Actually, there are no differences, but there are some technical issues. For the extramedullary device guide, the landmarks are available. All landmarks. You have the proximal tibia, the distal tibia, and it will not affect the fatty embolism or pulmonary embolism, as some cases or some literature suggested that intramedullary device have been shown an increase of the fat embolism. طبعا اللاندماركس هنا unlike the femur, that the femur it is very difficult to use the extramedullary devices. So in extramedullary device in tibia are very easy. And it will also reduce the risk of potential infection. And the most important thing is that when you have a tibial bow in varus knee, that may cause valgus cut in the intramedullary cutting device. So the extramedullary device is not affected by an anatomical malalignment, especially when you have a fracture previously in the midshaft, in the proximal, and you have malalignment, but you have a good alignment of the mechanical axis. So that's what you need. If there is an anatomical axis difficult, you cannot put the intramedullary device in that. So inadvertent fractures are avoided regarding the tibia. Some cases of revision surgery may need an intramedullary device in order when we are using stem offset, a long stem in the tibia is required. So there are many literatures suggesting both of them have no significant difference. And you can see here only the difference in the sagittal view regarding extramedullary device. We have a lower standard deviation than the intramedullary device, which means that this is more corrected in the posterior tibial slope. And this is the slope angle %. So what are these landmarks? احنا تكلمنا عنها بالمحاضرة الفائتة, which are either proximal and distal, and we use both of them, not only one. The proximal is that the medial and lateral tibial plateau, we are centered between them. And the tibial tuberosity are divided into 3 thirds. Between the medial and central third, we put this orientation line. Distally is that the tibialis anterior tendon rather than the shin of the tibia is used, in order that many have suggested that by Richard Scott, and others have suggested that it is not centered exactly for the tibial crest. The center of the ankle not only between the malleoli, it is off the center, just medially 3 millimeters. So that's why they do not use the second ray of the foot, because if there is any foot deformity. However, if you don't have it, or especially the case is not obese, you can use it as a second ray, the bimallular, from the lateral surface of the tibia to the medial surface of the tibia. And if you are really in doubt, use the CR fluoroscope intensifier. These pictures shows how is the center distally between the ankle joint. It is approximately 3 degrees, 3 millimeter away from the center of the tails. And you have seen these clamps, and there are indicator line. These indicator line, you can use it either medially and laterally until you have this point is exactly at the center of the ankle. We will talk about this anteroposterior diameter here. This is regarding the slope. We finish how we put the external device. The slope here, some of the system, they have built-in slope, which means that من هو بيها. يعني السلوب احنا مال الcut, when we are cutting the proximal tibia, it will cut 7 or 5 degrees from the anterior to the posterior. If the systems have this one, it's almost perpendicular, you can do this. The proximal part of the external device is fully attached with the anterior cortex, and here you can put it away 1 inch or 2 finger breadths. Remember that this one can control the AP diameter adjustment, and remember that the varus and valgus must be aligned firmly in order when you cut the proximal tibia, it will not show varus or valgus cut. It must be perpendicular. There are some cases that we don't need a slope. And these cases are the first situation when the presence of flexion contracture. When you have a flexion contracture with the posterior slope, it will add more contracture and it is difficult in extension. So no need for a slope here. The perioperative tibial reverse slope. Preoperatively, if your patient have in the lateral view a reverse slope, so from the posterior to anterior sloped, especially those who have high tibial osteotomy or healed of the tibial plateau fractures. And also the system designed with limited hyperextension, as those have risk of polyethylene peg wear or post wear if you do sloping, as you see previously in the X-ray. So no need for slope in these 3 situations. Some of the appeals is that when you are going to do tibial resection, a Hohmann retractor should be placed in the notch. In case of you are going to have a cruciate returning, this is a spiked Hohmann. If you are going to have a PS, don't use this one, just use a blunt one. But remember, if you are putting this away into the notch of the femur and you complete this resection, do not go medially and varusly, because here you may have a fracture. So almost always go in the center in order to translate the tibia anteriorly. Some of the surgeons, they prefer it from the lateral, as you see in this picture. This is the lateral and this, this is the lateral and this is the medial, sorry. Okay, so you don't have to go medially more. Be aware of that. Almost, you don't forget your 2 Hohmann retractor for the MCL and the LCL and patellar tendon. And here are what we see in the picture before, how is the cut is most perpendicular, and this is this cut when you have go for more valgus. So the next is the tibial sizing. Most of the system allow independent sizing of the femur and the tibia. So if you have one size or two larger the femur than the tibia, it is no problem. Some of these systems allow that. What's really important is that you aim to cap the bone and avoid overhanging. When I meant cap the bone is that you are fully put the tray on along all the proximal tibial cut. This discrepancy may occur if the bone is affected either by Paget disease or a fracture, so do not overhang it. Otherwise, it will cause an overstuffing of the medial or the lateral collateral ligaments and may cause infection and pain, especially in the lateral or the posterolateral. It may cause depopliteus impingement. Some among the tibial size, when you are going to have larger or smaller, almost do undersize the tibial tray. If you go there, you cover the laterally completely, shift it laterally, do not shift medially. And then if you have an overhanged, uncapped medial side, you can outline this and remove it. And this is very good thesis and very good study from 2004, that is correction of severe varus deformity in total knee by tibial component downsizing and resecting the uncapped proximal medial bone. So how about rotation? As we see, the tibial tuberosity and the rotation either with the femoral component. Some of the systems, they apply that when you are going to have this is a tile, and then put the component of the tibial tray with the polyethylene, it will rotate by itself. And these differences between them, if there are mismatches, it will not create a torsional force at the insert polyethylene junction, which means the backside wear, or the cement interface. So the tibial tray rotation, when doing a femoral rotation properly, you can put the tibial tray at the same femoral external rotation, and the system will allow the surgeon to handle the tray by rotation by this handle, as you see in this picture. And remember that the tibial tuberosity is almost on the lateral side, so that's why we are choosing it from the central and the medial third of the tibial tuberosity. So how about tibial trial component? After we finish all of them, sorry for this connection. Okay, after trial component, now we will start the trial component after resection. After the tibial resection, the posterior gap is sufficient for the femoral tile. Now you can use the tile of the femur inside. It is used by inserting a firmly plugged tile into the bone and to allow seating in extension. Remember that you have to cap all the way in the lateral condyle of the femur rather than the medial. It is for giving that to uncapped femoral medial condyle. So some of the femur in the first tile go in flexion. Sorry, again. Why does the femoral tile go in flexion? So divergence of the femoral cut under resection, it is divergent of the trochlear cut anteriorly, or under resection of the posterior condylar, especially in the medial, especially when you have a varus knee. So reapply the cutting box again and check the mediolateral dimensions. Check the mediolateral dimensions without overhanging laterally. So the medialize the component make the patellar maltracking in 30 degree of flexion. Remember that all osteophytes should be removed in both medial and lateral sides. So if you have got a posterior osteophyte, you have to put in your mind to remove it all. In order to release the posterior osteophyte, you have to either put a hook like this one in the femoral notch and elevate it whenever you can go, not forcefully. Otherwise, it may cause a fracture. A simpler way is that you make the assistance to push the tibia on the posterior side in a flexed knee, and then it will see this picture. As you can see the posterior condyle as much as possible in order to make the osteophytes are removed well with the use of a curved osteotome. So after that, we will go for ligament balancing. There are 3 methods, and all of them we can use is the gap balance, measured resection, and both. And in the next few webinars coming, there are controversies between both, but both of them must be used together. For the stability of the ligament, we should perform the following in the coronal plane, varus and valgus, and the flexion extension gaps. Adjusting flexion and extension gap, you can see either the gap is too tight, too loose, or balanced. So in A, it is the distal femoral cut that affects extension gap. In B, the posterior condyle, the cut that affects the flexion gap, and the proximal tibial cut affects both. Remember that certain releases and sizing of the component and the polyethylene are used before increasing the cuts. So here is how can we assess the balancing between flexion and extension. Here is an extension using the spacer block. Here is before we are doing the cuts, and here is the laminar spreader and the tension between both medial and lateral. Ligament balancing will be in the next webinar, but here are a few notes. If you are using a cruciate retaining design component, which is inserted first, if the femoral tile is inserted easily, there will be a good flexion gap. Remember that in PS design, the femoral tile component is inserted at 90 degrees, and then the tibial polyethylene together with the tibial tray is put there. So assess the flexion stability first. One of them is called polo test. Pull out, lift off. Is that when the anterior translation of the tibial tray, as you see in this picture here above, beneath the femoral component. رح يطلع أكثر من 3 mm, this means that there is a flexion gap is large. If it does, we will try how to manage this one. So it is loose in flexion, yes. If it is not, then we assess that its tightness. If the pull-out cannot be moved away, then you can see how is the tibial tray is lift off anteriorly. This is because that the lifted part from the lip of the polyethylene is seated along the femoral component. And this means it is tight in flexion. So in the CR design, as you can see here, this is a lift off, and after releasing the PCL, there is no lift off. So we have some situations regarding flexion and extension gap. If both of them are loose in flexion, loose in extension, which means that the flexion gap is large. So only you put a thicker polyethylene is required. This is the easiest one. And if you have both of them are tight, first of all, undersize the polyethylene. And if you are having a smaller size, and even though there is still tightness in both flexion and extension, a tibial resection is necessary. So بدال ما أنه إحنا نروح على tibial resection 0 رح نسويها +2. We reduce it. Note that the proper عفواً, note that the proper spacing of the flexion gap takes first place, and any residual tightness or laxity in the extension gap is corrected secondarily. Another situation is that when you have only extension tightness, which means that flexion is balanced. احنا اللي نريده انه اثنيناتهم يكونوا balanced. بنقول انه extension is tight, which means that there is an extra posterior, extra distal femur, or posteriorly there are osteophytes that prevent full extension. So what you do is that to release the posterior capsule, remove the posterior osteophyte, and as you see, by translating the tibia backwards, and then you remove all the posterior capsule. If it is still tight, then do recutting of the distal femur, as you see in this picture. What we have another situation is that tight inflection. Tight inflection, there is low flexion gap, which means that we have to increase it. Increasing the flexion gap, we have four priorities. First of all, check the tibial slope. If the tibial slope is very low, increase it, but do not increase more than 10 degrees, as the effect of the tibial slope into 2 degrees will affect every degree in the posterior slope of flexion. A flexion of 2 degrees will affect every 1 degree of the slope. Whenever you have a cruciate retaining, try to release the PCL and convert your implant into PS. And that's why we are suggesting that to use the PS is better, because of the flexion gap is larger. Downsizing the femoral component. Here you have to go through avoid notching. And you remember how to avoid notching by downsize, by checking the angle wing above the cutting slot anteriorly without notching the anterior cortex. And then, if it is still tight, resect the posterior condyle more. And these are the factors that affect the flexion gap regarding posterior condyle offset and the femoral rollback. Those are tight. How about loose? Loose in extension, balance in flexion. Loosening in extension, which means that there is a large extension gap. So upsizing the polyethylene will cause tightening also in flexion, and this will cause a situation 4 that we have just discussed. Downsizing the femoral component will cause loosening both flexion and extension. لأن إحنا إذا قللنا السايز مال الكومبوننت, it means that the anteroposterior diameter of the femur is reduced. So whenever you have reduced this, it will cause a situation number 1, lose flexion and extension, so add more polyethylene insert. If it is still loose, add distal femoral cement or augment if in cases طبعا بالاugments هي بالrevision surgery, when you have lost the posterior condyle, there are some distal femoral segment, and this is especially okay. So, and the fifth way is that when we have a loose in extension, so upsize the polyethylene. If you do increase the polyethylene thickness, it will cause tight also in flexion, like that of situation before. We just said it. And downsizing the femoral component. Downsizing the femoral component will cause as situation number 4, because both of them will be loose. So thicker polyethylene is insert. And the final thing is that to add distal femoral cement if it is less than 5 millimeter, and augments in cases of severe bone loss or in revision surgery. The sixth situation is that when you have large flexion gap, which means loose in flexion, shifting the femoral component more posteriorly in some system, as we said, it permits an anterior flange of 3 degrees. And upsizing the femoral component is one of the good solutions in treating a large flexion gap. إذا ماكو بعد كان a large flexion gap and still lose in flexion, you can add posterior condylar augments, or you can do a posterior capsular release osteophyte release, and it may change into situation number 4, which is loose in extension, also loose in flexion, so you can apply the polyethylene. This is a nice table from Parvizi. We said all the situation except situation 5 and 7. And you can see that there are differences between flexion and extension. So loose in flexion, tight in extension. So you try to first to correctly flexion loosening by upsizing the femoral component, filling the gap with cement and posterior femoral augment. This will correct the loosening on a flexion. And then tight in extension, you can resect distal femur more. The other thing is that when you have tight in flexion, loose in extension, the tightening in flexion, you can downsize the femoral component, and if you are doing so, there will be loose in extension, so you just add a distal femoral augment. And these are the situations that we are dealing with. So thank you very much. And the next webinar will be about the ligament release in varus and valgus. Thank you for your patience, and I hope that you are enjoying all. We will see some questions if you have. Thank you very much. Okay. Dr. Amna Al-Mubarak, very comprehensive, thank you. How can I get certificate attendance, please? Oh, sorry, we have no certificates. We are not a company or a special entity. We don't have it. I have just get previous. Listen. Thank you very much for your comments. Thank you, Dr. Ahmed Latif. If anyone have a comment or a question, please be my guest and have the mic. You can all unmute yourself. Thank you very much.
Thank you, Dr. Sinan. Thank you. It's nice talk, really. دكتور أحمد عزاوي.
أهلا وسهلا دكتور. أهلا وسهلا دكتور.
سلامات بين منشول إن شاء الله ماكو شيء إن شاء الله سلامات.
لا والله بس اختلاف بالجو صاير. لأن طفوا التبريد وبعدين حطوني بالحر اسكت وخليه.
والله سلامات. عاشت ايدك على المحاضرة حلوة وجميلة جدا يعني.
Thank you very much.
واستفادينا منها ممنون شكرا تسلم.
Thanks.
أهلا.
Thanks, Dr. Sinan. It's a really nice presentation.
Thank you, Dr. Wael.
Just, I would like just to ask you if, in your practical practice, you prefer in general, or your principle is to put the PS or in retaining according to your experience?
Well,
the practical.
I've learned from all our mentors are here and they are listening to me. I learned only the PS. We didn't have the CR image, CR cutting and it's a CR design, because many of the Oriental patients or the Middle East patients, they like to go more in flexion, and they don't need to have a special designs. Actually, most of the PS designs, they have, especially in the high flex gen, the Zimmer, and also the J&J and the amplitude, all of them, they have high flexion, so they like it. And most of the patients, they have been stable and in deep flexion. So I prefer the PS designs.
Thank you very much. Thank you.
Thank you. Do you prefer CR? I wish someone who is preferring CR and talk his experience here.
Yeah. Thank you, Dr. Sinam. We are
Thank you,
following you always. Huh? Thank you very much.
Thank you very much. Okay, I'm waiting for your question. Thank you very much for your compliments. Bless you all. Thanks a lot. Thanks a lot. Thanks a lot. Very comprehensive lessons. Okay. Oh, I see. You have Dr. Amna need a comprehensive session. Thank you very much. And certificate, as I see, I'm sorry, we have no certificates at all. And thank you very much for your compliments. So anyone have some of notes or questions regarding the total knee here? Please have the mic, and I'm very thankful. Okay. So in the next Saturday at July 25, in the same time and in the same link, there will be the ligament release. There will be also talk about severe varus and valgus knee for the total knee arthroplasty. Thank you for attendance, and goodbye, everyone. Thank you very much.